So first topic for today's crash course is poisoning. So I'll be discussing about three important topics. One is the basic thing, okay, how to approach unknown poison in a way of toxidromic approach, okay, and the second would be paracetamol poisoning, and third would be the extracorporeal removal of the toxins, okay. So first would be your toxidromic approach, okay. So what is toxidrome? Basically, this toxidrome is a combination of two important words. One is toxic, second is syndromes. So toxic syndrome together is known as toxidrome. This word was first coined by Moffenson and Greenshire. Okay, so what is toxidrome? It is a group of signs and symptoms which consistently result from a particular toxin. Okay, and to describe a better toxidrome, you should have the vital signs, you should have some end organ manifestations, and you require even few lab parameters to tell that yes, this person or a patient has consumed this type of toxin, right? So what are the end organ manifestations we are speaking about? The first one is your CNS. So we are going to check the mental status of the patient. We are going to check the ophthalmic system in the form of the pupil size. We'll check the gastrointestinal system function in the form of presence or absence of peristalsis, dermatologic system as whether the skin is dry or patient is diaphoretic, whether the mucous membrane is dry or moist, and the last is your genitourinary system in the form of urinary retention or the urinary incontinence. So these are the end organ manifestation in a toxidromic approach. Now, how to approach any patient who has present with an unknown poisoning? So the first important thing is history. So in history, a lot of things are required to come to a specific diagnosis, but three important things. One is what type of a drug overdose or the substance abuse the patient has taken. Second, whether this patient has a suicidal ideation or any prior suicide attempt. And third is whether there is a history of psychiatric illness. So these are the important things apart from the history which you usually collect, what type of drug, what is the amount, when did he consume, whether you went to the previous hospital, any gastric lavage given. Apart from all these three are a very important history that you should obtain from the relatives. Now coming to the vital examinations. So four things, your blood pressure, pulse rate, respiratory and temperature, they form one of the important vital signs in a toxidromic approach. So we'll discuss about each of it. So first is blood pressure. So you should know the mechanism of action, how this blood pressure presentation occurs in case of a poison patient. Now, drugs which cause hypotension or toxins which cause hypotension. So what is the mechanism behind that? One is there is decreased peripheral vascular resistance. There is myocardial depression in the form of decreased myocardial contractility. There could be arrhythmias and there could be a depletion of intravascular volume, all leading to hypotension with certain group of drugs. Now, second group of drugs is those drugs which cause orthostatic hypotension without causing any marked supine hypotension. Why does this occur? Because these drugs, they usually affect the autonomic control of the heart or the peripheral capacitance vessels. Now coming to those drugs which causes hypertension, especially your sympathomimetics. So how do they act? They act on CNS by causing sympathetic overactivity. They cause increased myocardial contractility and increased peripheral vascular resistance. So these are the mechanisms by which hypotension or hypertension results in case of a poisoning. Now, you should, when they ask about toxidromic approach and we write about each signs and symptoms, so about the vital signs, at least mention 5 to 6 drugs which causes either hypotension or hypertension, important drugs. So hypotension, we all know beta blockers, calcium channel blockers, ARBs, AC inhibitors, okay, tricyclic antidepressants, ethanols, opioids, sedative hypnotics, most common drugs. These causes hypotension. Now, hypertension is caused by alpha-1 adrenergic agonists, ergot alkaloids, monoamino oxidase inhibitors, nicotine, and all the sympathomimetics. These cause hypertension. Now, the second important vital sign is your pulse rate. So, for a normal pulse rate, there should be a balance between your sympathetic as well as your parasympathetic tone. Reflex tachycardia usually occurs because of hypotension, vasodilatation, or because of the underlying hypovolemia. Reflex bradycardia occurs when there is an abrupt hypertension, which occurs occasionally. So, usually the tachycardia is common of two important poisoning, the sympathomimetic drugs and the anticholinergic drugs. But how to differentiate between the tachycardia when a patient comes with any other consumption? Okay, so in sympathomimetic toxicity, this tachycardia is usually accompanied by diaphoresis and increased bowel sounds. Whereas in anticholinergic toxicity, the tachycardia is usually accompanied by dryness, that is decreased sweating, absent bowel sounds, and there will be a urinary retention. So this is how you differentiate tachycardia, which is present in a patient, whether it is sympathomimetic origin or because of the anticholinergic toxicity. Okay, and one more thing you need to remember about the relation between the pulse rate and the temperature, because certain drugs cause hyperthermia leading to increased tachycardia. Okay, so the pulse rate increases approximately 8 beats per minute for each 1.8 degree Fahrenheit or 1 degree Celsius elevation in temperature. So now examples of the same. So examples, drugs causing or toxins causing bradycardia is your same. Alpha 2 adrenergic agonists, beta blockers, calcium channel blockers, your famous OP compounds, carbamates, opioids. Okay, so all these causes bradycardia. Coming to the tachycardia, anticholinergics, antipsychotics, tricyclic antidepressants, your methylxanthines, and the sympathomimetics. So these cause tachycardia. Now coming to the temperature, the third vital sign. So you call hypothermia when the temperature is less than 95 degrees Fahrenheit or less than 35 degrees centigrade, and hypothermia when the temperature is more than 100.4 degrees Fahrenheit or more than 38 degrees Celsius. So what are the common causes of hypertension? Common causes of hyperthermia. Okay, one is environmental heat stroke, extreme psychomotor agitation, or xenobiotic related temperature disturbances, which are usually seen with malignant hypothermia, serotonin toxicity, or your neuroleptic malignant syndrome. Okay, also certain drugs which may contribute to hypothermia are anticholinergics, antiepileptics, antihistaminics, antihypertensives, antipsychotics, and diuretics. So usually these environmental heat stroke, malignant hypothermia, they all result in life-threatening hypothermia, which may lead to extensive rhabdomyolysis, AKI, and sometimes direct liver as well as brain injury. Okay, whereas certain drugs like your ethanol, CNS depressants, and general anesthetics may cause hypothermia. So we've already discussed what causes hyperthermia and what causes hypothermia. The other examples of hypothermia are your general anesthetics, carbon monoxide, ethanol, hypoglycemics can also cause hypothermia. Now the fourth one is your respiratory rate. Okay, so what causes hyperventilation? What causes hypoventilation? So hyperventilation is usually caused by CNS stimulants like salicylates, which mainly acts on the brainstem. Whereas your bradypnea or hypoventilation is usually caused by your opioids, sedative hypnotics, and these also directly act on the brainstem, leading to decreased respiration. In case of cyanide or carbon monoxide poisoning, okay, the patient initially has a fast respiration, and as if you don't give the treatment and as the concentration of the cyanide and carbon monoxide increases, then there occurs bradypnea and slowly respiratory arrest. Now, causes of bradypnea. So your OP poisoning, carbamates, all your ethanols, okay, and your opioids. Okay, all these lead to bradypnea, whereas tachypnea occurs usually in the earlier stages of cyanide toxicity, ethylene glycol's toxicity, methanol ingestion, methyl xanthis, and in the early stages of nicotine consumption. So these are about the vital signs. Okay. So heart rate, BP, respiratory rate, and temperature. And what are the drugs that are causing each of this? So this is the first part of the toxidromic approach. Second is your end organ signs, which I've already mentioned. So we'll see which of these drugs cause the end organ findings. So first one is your ocular findings. So here you should know which are the drugs which causes miosis, which are the drugs which causes mydriasis. So miosis, your pupillary constriction, is most commonly caused by your barbiturates, OP compounds, carbamates, all types of alcohols, okay, and your physostigmine. All these causes meiosis. Your mydriasis is caused by all your sympathomimetics like amphetamines, anticholinergics, antihistamines, cocaine, any drug withdrawals, MAO inhibitors. All these cause mydriasis. Now, second comes your mental status and behavior. Okay, your CNS. So you should know which of the drugs which causes CNS depression, CNS activation, and which causes delirium. Okay, so all of the sympathomimetics usually cause elevated mood, right? Whereas all your sympatholytics and cholinergics, sedative hypnotics, and narcotics, all these causes CNS depression. Whereas some drugs even cause delirium and confusion, like your alcohol or any drug withdrawal, anticholinergics, antihistamines, carbon monoxide toxicity, and salicylates. Okay, this is about the mental status. Now coming to the seizures. So which of the drugs which have seizure potential? Okay, the most commonest is your amphetamines and your anticholinergics. These both have a high incidence of seizures. The others could include your tricyclic antidepressants, your carbamates, your ethylene glycol, lithium toxicity, OP poisons, and your hypoglycemic agents. Okay, these are some of the examples causing seizures. Now coming to, this is about the end organ things, about two important. One is your CNS, one is your ocular manifestations. Next comes your laboratory investigations. Okay, so some important laboratory investigations which also help in toxidromic diagnosis are, first one is your anion gap. Okay, so anion gap, everyone knows the causes of elevated anion gap and your decreased anion gap or a normal anion gap. Okay, so I'm not going to go in detail about the causes of the elevated or decreased anion gap, as you all know that. So in the toxic ingestions, it would be ethylene glycol, methanol, paraldehyde, salicylate, and any of the alcohols. Okay. Now coming to the osmolar gap. This is very, very important. Okay. If the patients had an elevated anion gap, try to calculate the osmolar gap. So what is osmolar gap? It is measured osmolality minus your calculated osmolality. Okay. So calculated osmolality, I know you people know about the formula, which includes your sodium, urea. Okay. So yeah, coming to measured osmolality. So measured osmolality, this can be done by two methods. One is your vapor pressure osmometry, and the second one is freezing point depression osmometry. Okay, your vapor pressure osmometry usually does not detect volatile alcohols such as ethanol and methanol. However, it detects ethylene glycol. But for us, the most important ones are your alcohols, the common alcohols which are available. So the best way to measure these alcohols are your freezing point depression osmometry, which actually measures all of the solutes. Okay, so a osmolar gap, normal osmolar gap is less than 10 milliosmoles per kg. And if there is any increased osmolar gap, then the causes of that include ethanol, ethylene glycol, propylene glycol, sorry, glycerol, even your IV immunoglobulin, because it contains maltose, that also causes increased osmolar gap, mannitol, methanol, any radio contrast media, and sometimes even hypermagnesemia, severe hypermagnesemia also leads to osmolar gap. So anion gap, osmolar gap. The next gap is your oxygen saturation gap. Okay, so what is the oxygen saturation gap? It is the difference between the oxygen saturation, which is measured by your pulse oximetry, that is your SpO2, and the oxygen saturation level, which is calculated by your ABG. Right? So the difference should be less than 5%. If it is more than 5%, then there is a presence of either carbon monoxide poisoning, methemoglobinemia, cyanide poisoning, or presence of hydrogen sulfide. Okay, so the best way to confirm this is your co-oximetry. Okay, so these are the three laboratory findings which are important for us. So one is your anion gap, one is your saturation gap, and one is your osmolar gap. Okay, now coming to the examples of these toxidromes. So when they ask about toxidromic approach, so first mention what is it. Second, you should mention about the vital signs and each of the vital signs examples. Second one be your end organ manifestations with examples. Third is some of your laboratory parameters examples, and you can just mention about one of the toxidrome which you actually know. Okay. So you can either mention about anticholinergics, narcotics, or any other examples in detail. Okay. Now coming to the first one, your anticholinergics. So usually they resemble sympathomimetics, and the most important, the mechanism of action is they block the acetylcholine, by which it activates the nervous system through muscarinic and nicotinic receptors. Right. So now coming to the features. So we have seen all of the approaches. Okay, what causes what? So anticholinergics usually cause mydriasis, blurred vision, their temperature is raised, they cause dry skin flushing, they cause ileus, urinary retention, tachycardia, hypertension, sometimes psychosis, coma, seizures, and in rare cases, myoclonus. So coming to the drugs which cause all these. Okay, your antihistaminics, atropine, baclofen, benztropine, tricyclic antidepressants, phenothiazines, scopolamine, all these causes the anticholinergic toxidrome, where all these features are present in these type of toxins. So what is the drug treatment? So it is physiostigmine, but in case of tricyclic depressants, the treatment is different. Don't try to use physiostigmine in these cases because it causes life-threatening events. Okay, and also causes some conduction abnormalities in the heart. Okay, so these you have to write like this, one example in detail. Okay, so this is about anticholinergics. Second is your cholinergics. Okay, so you can write about your OP compound. So everyone knows about the OP compound. So you can write about the OP compound. So cholinergic toxidrome. So you all know the features. You have the sludge, salivation, lacrimation, urination, diarrhea, GI cramps, and emesis. Okay, so drugs, your organophosphorus, carbamates, physostigmine, and pilocarpine are the drugs which cause cholinergic symptoms. So drug treatment, we all know atropine and pralidoxine. Now coming to the narcotics. Okay, so narcotics, the most common is your opiates. So these patients have a shallow breathing, altered mental status. Here it causes meiosis. There is bradycardia as well as hypotension, hypothermia, and decreased bowel sounds. So what is the antidote for this? It is naloxone. And how to give naloxone? What is the dose of naloxone also is very, very important. Okay. So the dose of naloxone is you need to dilute 0.4 mg in 10 cc of NS and titrate a patient, okay, till the patient starts breathing. Okay, so each ml contains 0.04 mg. Okay, so you have to give 1 ml every 2 minutes. Now next comes your sedative hypnotics. So you have your benzodiazepines, barbiturates, anticonvulsants, antipsychosis, antipsychotics. So all are included in your sedative hypnotics. So usually patient presents with stupor and coma, confusion, apnea, and slurred speech. So the drug treatment would be naloxone, flumazenil, and urinary alkalization for phenobarbital. Similarly, you have your sympathomimetics where you have your beta adrenergics, alpha adrenergic, and a combination of beta and alpha adrenergics. So when you have time, you can just go through it. The other toxidromes include hallucinogenics, like your amphetamines, cannabinoids, cocaine. All this come under hallucinogenics, and your extrapyramidal toxidromes. Okay, rarely even haloperidol, respirin, and olanzapine may also lead to rigidity, tremors, hyperreflexias. Okay, so these are the examples of toxidromes which you have to write in your exams. Maximum two, but at least one in detail. Okay, so this is how you need to write when they ask about toxidromic approach of a unknown poisoning, right? So the others are serotonergic drugs and epileptogenic drugs. So these are very rare. So this completes the first topic. Now coming to the second one, paracetamol poisoning. Okay, so very, very important type of poisoning, most asked question in your exam. So paracetamol is usually anyl derivative and it has a lots of different names. It is also known as acetaminophen. It is also known as N-acetyl P-aminophenol. So what is the mechanism of action? It is a weaker or a selective inhibitor of your cyclooxygenase enzyme. Okay, it has anti-analgesic and antipyretic action, but it doesn't have a peripheral anti-inflammatory properties. Okay, so what is the pharmacokinetics or dynamics about the drug? So when they ask about any drug, so you should give the introduction as pharmacokinetics, pharmacodynamics. So when there is an ingestion of a therapeutic dose, so what happens? It is rapidly absorbed into your duodenum and it forms a weak acid. And your peak concentrations will reach within 30 minutes to 2 hours, and it has 100% bioavailability, and usually within 4 hours when you measure the serum paracetamol concentration, it will be around 10 to 20 mg per ml. It is around 20% protein bound, and the volume of distribution is around 0.85 liters per kg. The elimination half-life is around 2.5 hours, and as told, the therapeutic concentration for the antipyretic effect should be usually 100 to 20 mics per ml. Okay, I'm so sorry, this is mics here. So this is about the pharmacodynamics and pharmacokinetics of the drug. Now coming to the metabolism. This is very, very important for us because paracetamol toxicity usually involves this metabolism part of the drug. Okay, so there are two important ways by which the drug is metabolized. So the major form is by glucuronization or the sulfation process, where there is a production of some non-toxic metabolites which are usually eliminated in the urine. Around 5 to 10% of the drug is also metabolized to your NAPQI through the cytochrome P452E1 route. Okay, and this NAPQI is actually toxic. But because of the presence of glutathione in our body, this NAPQ is converted into the non-toxic form like cysteine and other compounds which are then excreted in the urine. Okay, so the normally around this part of a small amount, around 5 to 10% of NAPQ is formed. But because of the glutathione stores in our body, it gets converted to non-toxic forms and get excreted. This is the normal metabolism. Now coming to the toxicity. So how does paracetamol toxicity occurs? So when a lot of drug, okay, other than your therapeutic dose is being ingested, okay, so what happens? Your glucuronization and the sulfation pathways become saturated, right? So most of the drug which can be metabolized will be metabolized, but the remaining drug will go into your second pathway, which is your cytochrome P450 pathway. So what does this do now? There is production of increased amount of your NAPQI. Okay. So this NAPQI, it cannot be completely neutralized by some amount of glutathione stores which are present in our body. Okay. Because there's a lot of NAPQ which is formed now. So what happens? The remaining part of the NAPQ which is present in the blood or in the blood will lead to oxidative stress and mitochondrial dysfunction, which leads to depletion of ATP stores, leading to hepatocellular necrosis and cell death. Okay, so this is what happens in case of your paracetamol toxicity. Okay, so this is the one. If you want to make it uh, more a better answer in your exam, so please you can put this diagram and you can mention. So paracetamol 80 to 90% glucuronide and sulfate conjugates are formed. Around 5 to 10% because of the cytochrome enzymes it is converted to NAPQ, okay, which is usually toxic. But because of the glutathione stores which are present in our body, it gets converted to cysteine and mercaptouric acid conjugates, which are usually non-toxic and excreted in the urine. Okay. So one more thing you need to mention when you're mentioning about the pathophysiology of paracetamol toxicity is, so paracetamol induced toxicity or hepatic injury is basically a centrilobular type of necrosis. Okay. So this is about the toxicity or the pathophysiology. Now coming to the toxic dose of paracetamol, which causes all this damage. So a single ingestion of more than 10 grams or 200 mg per kg, that could be leading to the toxicity. Second, more than 10 grams or the same 200 mg per kg over a 24-hour period as a staggered dose. Third, more than 6 grams or 150 mg per kg per 24-hour period for at least 2 consecutive days. Okay, so all these causes the toxicity, paracetamol toxicity symptoms. Okay, and in those patients who have already a acute liver failure, even the therapeutic dose which you give might also lead to toxicity. Okay, that is known as your therapeutic misadventure. Okay, so we have seen. So whether all these patients develop toxicity for paracetamol? No, there are certain risk factors which are important for the development and the manifestations of paracetamol toxicity. So the first risk factor is any ingestion of massive doses, like more than 30 gram. Okay, so that is one of the first risk factors. Second, if the paracetamol is together ingested with your alcohol consumption. Okay, because alcohol consumption will lead to CYP231 induction. Okay, which may lead to increased NAPQI formation. Also in these alcoholics, there is poor nutrition and lower glutathione stores. Okay, so which further makes them more prone for toxicity even at lower levels. Any enzyme inducers, your P450 enzyme inducers, like your anti-seizure medications, can cause increased NAPQ production. Next, if the patient presents in the later stage, like more than 48 hours, or if the patient is consuming from modified release or extended release paracetamol, okay, or those patients who have prolonged fasting, who are malnourished or anorexic, so these patients have decreased glutathione depletion or stores are not adequate, so that is one of the risk factor. Repeated supratherapeutic ingestion and staggered overdoses, okay, and any genetic polymorphisms, and if there is a drug-induced liver injury which is already present and upon which you are giving a paracetamol, then that is also leading to a severe toxicity. So these are the risk factors. Now next comes your risk assessment. In risk assessment, two important risk assessments are very important. One is your biomarkers and one is your Rumac-Mathew normogram. Now first, biomarkers. So these biomarkers, they usually determine the risk of toxicity. They are needed for the treatment and also to know how much the treatment is effective. Okay. So what are those tests or the biomarkers? One is your serum paracetamol concentration. Second, your LFTs. And third is your INR. Okay. So in this, your ALT and AST are very, very important. Okay. So paracetamol induced hepatotoxicity is generally defined as either AST or ALT elevations of more than 1000 international unit per liter. In severe toxicity, even the concentration may be elevated more than 10,000 also. And most important is your ratio, AST to ALT ratio, which is known as D-Ritis ratio. So normally, both rise in 1:1 ratio. But when you consume paracetamol, okay, at the presentation, if when you measure the ratio, it is more than 2, then it is associated with poor prognosis. Or suppose if it is not paracetamol poisoning, then it will be usually associated with chronic excessive alcohol ingestion. So this is not the specific biomarker for paracetamol ingestion, but in general, this is the one. When the ratio is more than 2, it indicates worse outcomes in cases of paracetamol poisoning. So next comes your Rumac-Matthew normogram, very important one. So it helps in estimating the risk of liver toxicity and thus whether treatment with N-acetylcysteine is indicated or not indicated. Okay, so concentrations which are lying above the line, what is that line? I will let you know. Indicate that patients require acetylcysteine, and concentrations more than double the line indicates an even greater risk. So what is that? I'll show you in the next slide. And important thing you should remember is it is not useful to predict risk for either late presentations or the staggered or the repeated overdoses. So in such cases, you need not, your Rumac-Matthew normogram cannot be used. Okay, so this is the one. Very, very important. So this is time since ingestion, and this is the acetaminophen blood concentration in microgram per ml. Okay, so this was first given in 2012. Okay, so basically, when do you start marking this Rumac-Matthew normogram is, it begins at 200 microgram per ml at 4 hours after ingestion. Okay, there it starts. Okay, so there are two lines which I've already spoken in the previous slide. One is known as the treatment line, also known as the safety line. So this is the line. So this begins at, if you see the concentration, it is 150 microgram per ml at 4 hours. Okay, which was derived at 25% lower than the original normogram line. Okay, now the second line usually begins double the dose, 300 microgram. So 300 microgram per ml at same 4 hours, okay, which was derived as 50% greater than the original normogram line to denote patients with increased risk of developing lung injury. Okay, so two lines. One is the treatment line, which is also known as safety line. Okay, and this is the high risk line. Okay, so 150, 300, both at 4 hours. Okay, so acetylcysteine should be initiated if a serum or plasma acetaminophen concentration, which is drawn 4 to 24 hours after ingestion, falls on or above the treatment line. Okay, on or above the treatment line. If any patient comes and you have measured, and the patient comes within 4 to 24 hours, you have measured the serum paracetamol level, and you should draw this normogram, and if it falls within the treatment line or above that, then you give N-acetylcysteine. If it falls below the treatment line, need not to give your N-acetylcysteine. Okay, but in most of the cases, we don't, your paracetamol levels are not available. So in such cases, okay, you can actually give your paracetamol, N-acetylcysteine if the patient comes within 4 to 24 hours. Okay. So this is just an arbitrary concentrations after the ingestion. So as I told, at 4 hours, usually the concentration of paracetamol will be more than 150. Similarly, at 24 hours, it will be more than 4 microgram per ml. So this is about the risk assessment. One is with the help of biomarkers and one is with your Rumac-Matthew normogram. Next, coming to the clinical presentation. So whenever you're writing a clinical presentation for paracetamol poisoning, it should be in stages. Okay, so it is stage 1, stage 2, stage 3 and stage 4. Stage 1 starts from 0.5 to 24 hours. So Here, some patients could be asymptomatic or could have some mild symptoms like nausea, vomiting, diaphoresis, pallor, lethargy, and malaise. And when you measure here, mostly the laboratory tests could be normal. In stage 2, which is 24 to 48 hours, there is slowly some evidence of hepatotoxicity and even some nephrotoxicity that is present, and patient might be complaining of right upper quadrant pain because slowly the liver enlargement will be present. And those who are subclinical, your laboratory tests might become abnormal here. So your bilirubin, PT, and your liver enzymes may be elevated. Now in stage 3, which is 72 to 96 hours, very, very important period. So here your enzymes will rise to a very high levels. There is a lot of derangement in your coagulation profile. Along with this, the patient might have clinically hypoglycemia. There could be lactic acidosis. When you measure ammonia, it is on the higher side. And since there is coagulopathy, there could be bleeding diastasis, acute renal failure, jaundice, and even hepatic encephalopathy. So this is the most important period, okay? Because slowly, if the patient is worsening from this period, then death is most common in these patients. Now, stage 4, if the patients cross this period, which is from 4 days to 2 weeks, it is a recovery phase. Or if the patient is worsening or fits into a transplant criteria, then transplant can be done. Or if the patient worsens further, death. Okay, so past 4 days, all these can occur. And the symptoms and laboratory values may take weeks to normalize. So don't expect a to normalize all your lab parameters within this period. Okay, so this is a clinical presentation and you need to mention this in stages. Now coming to poor prognostic markers. Okay, so what are the poor prognostic markers? Your ALT levels more than 1000, INR more than 3. If the patient has AKI with oliguria, pH less than 7.3, lactates more than 3, and symptoms like hypoglycemia, thrombocytopenia, severe hypotension, and encephalopathy. All these are poor prognostic markers. Now coming to the treatment. So the first initial treatment, if the patient comes within 2 hours of ingestion, then the best way is to do a decontamination is by activated charcoal. Okay, so this activated charcoal usually binds paracetamol and reduces the amount of paracetamol absorbed from the GIT. So done only if the patient presents within 2 hours of ingestion. Suppose if there is a massive overdose or if the patient has consumed some extended release preparations, then you can also give gastric decontamination up to 4 hours. Okay. And some studies have shown that this charcoal may reduce the peak paracetamol concentrations, the need for NAC, as well as it decreases the risk of hepatotoxicity. Okay. Now, second one, the most important, the antidote, the N-acetylcysteine. So, how does this N-acetylcysteine act? Mechanism of action. So, it avoids toxicity by preventing the binding of NAPQI to hepatic macromolecules. How? Because it restores the glutathione. Okay, by replenishing the cysteine, which is the rate limiting factor for glutathione synthesis. And the risk of developing hepatotoxicity is reduced when you give NAC within 8 hours of ingestion. So according to the guidelines, it is within 8 hours of ingestion, but you can extend even up to 24 hours. Okay. So this is the mechanism as I told. So the steps are the normal. So glucuronidation, sulfation will act and your P450 enzyme. So excessive amount will go to this P450 enzyme, which may lead to the production of your NAPQI. So what does NAC do? It increases the glutathione stores in the body and converts this NAPQI into the non-toxic products and these non-toxic products are getting excreted into the urine. Okay, so this is the mechanism of action. Now, indications, as I told, best within 8 hours, but can be extended to 24 hours. And it depends upon the levels. Okay, so 150 at 4 hours or 50 at 10 hours. And if it is an acute poisoning, okay, which is ingested within 1 hour with no other products containing acetaminophen in the past 24 hours, then that is an indication. Basically, not a staggered dose, then you can give N-acetylcysteine. Okay, acute poisoning with no ingestion of any sustained release formulations. So extended release or sustained release, then you can give NAC. Okay, and it's used, as I told, ideally within first 8 to 10 hours with risk of hepatotoxicity being less than 5%, especially if your paracetamol level is above the treatment line. So that is very, very important. Above the treatment line is also very, very important. Okay, and where this Rumac-Matthew or serum paracetamol levels are not available, then empirical use when these levels cannot be obtained within 8 hours of ingestion. So we all most probably give N-acetylcysteine as an indication. This is the last indication which we all give. Okay. Now this NAC can be available as oral or IV formulations. So the most common we use is the IV formulation. So IV, it is available as 20% solution. In the oral, it is available as 20 as well as 10% solutions. So remember any one thing, just mention that it can be given orally or IV, but mention your IV dose. Okay. So the loading dose, it is 150 mg per kg in 200 ml 5% dextrose, which is given over 15 to 60 minutes. The maintenance dose will be 50 and then 100. So 50 over 4 hours and 100 over remaining 16 hours. Dilution is very, very important. 50 in 500 ml 5% dextrose and 100 in 1 liter 5% dextrose. Okay, so duration of therapy totally will be 20 or if it is 21 hours. So we should monitor for drug-related adverse effects and presence of any anaphylactoid reactions. So this is the flow chart which is showing about how to go with treatment of paracetamol poisoning with N-acetylcysteine if there is an availability of paracetamol concentration, measurement of paracetamol concentrations. So history is reliable and the patient has ingested and it come within 0 to 24 hours. Do the decontamination if possible. If the patient has arrived within 2 hours, then measure the paracetamol levels. Okay. So 0 to 4 hours, 4 to 8 hours, 8 to 24 hours, and more than 24 hours. Okay. So start N-acetylcysteine while waiting if ingestion is more than 30 gram or if acetaminophen concentration will return after 8 hours. Okay. So in such cases, you just plot the acetaminophen concentration, see whether the patient is below the treatment line, above the treatment line, or above the high risk line. So below the treatment line, no need to administer N-acetylcysteine. Above the treatment line, the normal dose of N-acetylcysteine. But if the patient is above the high risk line, okay, that is 300 mg in 4 hours, then some guidelines tell that you can give a high dose of N-acetylcysteine, but I couldn't find any high dose uh, regime for paracetamol toxicity. Or they tell you can give extended NAC. Okay, extended NAC. Just within 20 hours, you need not to stop. You can extend the NAC concentration until your patient improves. Okay, so this is above high risk line. Okay, so this is how you give N-acetylcysteine, and when to stop N-acetylcysteine is very, very important. One, when your acetaminophen concentration is less than 10 microgram per ml, your INR is less than 2, your AST ALT is normal for the patient, or if elevated, have decreased at least 25 to 50% the peak, and if your patient is clinically well. Okay, if all these criteria are met, then you can stop your NAC. Okay, if it's not met, you can give your extended NAC. So in your extended NAC, what you give is the last one. Okay, 100 milligram per kg over 16 hours. This is the dose you give in the extended NAC. Okay, now what are the other drugs which can be used in paracetamol toxicity? So initially they were even using methionine. Okay, but methionine has a lot of side effects, so they have stopped using methionine because that also provides glutathione indirectly. Now, second is your cimetidine. Now, cimetidine, fomepizole, both of these drugs, they inhibit your enzyme CYP2E1. Okay, so hence they saw that they have some role in paracetamol poisoning. And the last drug is your magnesium superoxide dismutase, okay, which is also known as calmangafodipir. Okay, so it is a mitochondrial protein which scavenges free radical and can prevent the mitochondrial injury, which is usually seen with paracetamol poisoning. So these are the other drugs which can be used if there is an availability. Okay. And the last one is in the treatment is your liver transplantation. So liver transplantation referral, we have your King College criteria. So what is the King College criteria for paracetamol poisoning? If the pH is less than 7.3, irrespective of the grade of encephalopathy, or if your prothrombin time is more than 100 seconds and creatinine levels more than 300 millimole per liter, and patients in grade 3 or grade 4 encephalopathy. Okay, so this is for paracetamol poisoning. So patients that undergo liver transplantation due to paracetamol liver failure have a good clinical outcomes with a 5-year survival rate was really good. It is 70%. But if those patients who actually require liver transplantation and we are not able to, patient is not able to go for it, then the mortality rate is up to 30%. Okay. So this completes your paracetamol poisoning. Now the last comes your extracorporeal therapies for toxin removal. Okay, so very, very important. So it is known as ECTR, extracorporeal toxin removal. Okay, so it represents a treatment modality which promotes removal of endogenous or exogenous poisons and supporting or temporarily replacing a vital organ. So what is the role of ECTR in poisoning? Okay, so one is if the patient has a life-threatening toxicity, okay, then you can give an option of ECTR to the patient. Second, if there is prolonged admission in the ICU with coma and mechanical ventilation, especially with barbiturate overdose, then in such cases you can give an option of ECTR. Third, any likelihood of permanent disability, especially with methanol overdose. Okay, loss of vision is more common with methanol overdose. If that is the case, then you can give an option of ECTR. And third, those patients, they develop toxicity despite your standard supportive measures and your antidotes if available, still the patients is having life-threatening toxicity, then that is an indication for your ECTR. Okay. So when they ask ECTR, what is it? What is extracorporeal treatment definition and what are the indications? General indications. And third is you need to mention about something known as XTRIP. What is XTRIP? It is a multidisciplinary and a multinational collaborative which is known as extracorporeal treatment in poisoning work group, which has been established with the aim to clarify the role of ECTRs in clinical practice through the development of evidence and expert opinion based recommendations. Okay, so these are the group of people who are have done a lot of work on this extracorporeal therapies in toxins. Okay, now, so what are the properties of the toxins or the drugs for an extracorporeal therapies? Okay, so 5 important properties you should remember. One is the molecular size of the drug or the toxin, the protein binding of the drug, volume of distribution, water solubility, and endogenous clearance. These are the 5 important properties of the drug if it has to undergo a extracorporeal removal. In addition, some technical aspects of the procedure may also determine the extent to which a drug is removed. Now, in short, what are the single line that you need to mention in your exams? Okay, so first one is molecular weight. We all know that smaller molecular weight substances will be able to easily get cleared off through the membranes, your dialysis membranes, more easily than the larger molecular weight substances. Okay, so your toxin should have a smaller molecular weight to get removed from an extracorporeal treatment. Second, protein binding. So if the drug is bound to the proteins, then the free form of the drug in the blood is less, so it cannot be removed. So it should be free. The protein binding should be less. Then only the drug can be removed easily. Okay. Third is your volume of distribution. So a drug with a large volume of distribution. What is volume of distribution? So when a drug is given, it goes and settles into the different organ systems or distributes into the different organ system. So if there is a large volume of distribution, they tell that if it is more than 1 liter per kg, then what happens? All the drug from the blood will go and settle in one of the organ. So it cannot be removed out from the plasma. So it is minimally dialyzed. So your volume of distribution should be less than 1 liter per kg to get excreted through the extra corporeal therapies. Okay, so small molecular weight, less protein binding, and less volume of distribution. Okay, next, water solubility. So we all know that the dialysate which is used for hemodialysis, it is in the aqueous solution. Okay, so it is water soluble. So any drug which has a high water solubility will be easily removed from the extracorporeal therapy. In other words, lipid soluble drugs will not be able to get cleared by an extracorporeal therapy. So there should be high water solubility. And the fourth one is endogenous clearance. Okay, what do you mean by endogenous clearance? So, all of our drugs in the body get metabolized either through renal or non-renal mechanisms. So, in non-renal, the most important one is your hepatic clearance. Okay. So, your endogenous clearance should be less if the drug has to be removed by a dialysis or any other extracorporeal therapy. So dialysis will have a limited impact if the rate of drug removal is significantly faster by endogenous routes. How much fast? More than 4 ml per kg per minute. Okay, so endogenous clearance should be less. So these are the 5 important characteristics of the drugs that you should know when they ask about the extracorporeal removal. Done? So coming to the basically different methods by which we can do this extracorporeal therapies are hemodialysis, hemofiltration, and hemoperfusion. I'll come it in the later slides. So this is nothing but the molecular weight. So if the molecular weight is less than 500 daltons, it can be easily removed by hemodialysis. For hemofiltration and hemoperfusion, even if you see kilodaltons it is. So high molecular weight toxins can be removed by hemofiltration and hemoperfusion. Now protein binding, as I told, it should be low. So if it is low, then it can be removed by hemodialysis. Hemofiltration also, the protein binding should be less. But if it is a hemoperfusion, even if the toxin is highly protein bound, you can remove it with hemoperfusion. Now coming to the volume of distribution. So everywhere if you see, it should be less volume of distribution. Solubility, yes, it should be water soluble, but hemoperfusion can even remove your lipid soluble drugs. And endogenous clearance for all, as I told, it should be less than 4 ml per kg per minute. Okay. Now, as I told, modalities. So one is your intermittent hemodialysis. Second is your CRRT. Third one is your hemoperfusion. Fourth one, even with therapeutic plasma exchange, where your immunoglobulins can be removed. Okay, so these are the 4 methods of extracorporeal treatment for the removal of the toxins. Now, you should write at least 1 or 2 lines about the advantages of this type of extracorporeal removal for toxins. Okay, so we all know that hemodialysis, intermittent hemodialysis is basically a diffusion which is against the concentration gradient. Okay, so all know about the mechanism. Okay, so for drug removal, there are 2 types of intermittent hemodialysis. One is the standard one, and second one is the high flux modalities. Okay, so in high flux modalities, usually the pore size will be bigger, the dialysate flows will be higher. So the amount which can be removed is much higher in the high flux modalities. But the only drawback with this intermittent hemodialysis is after stopping the dialysis, there will be rebound toxicity. Okay, that is a main drawback of intermittent hemodialysis. So how to prevent this rebound toxicity? Either you increase the frequency of the sessions in a day, 2 to 3 dialysis, or you better shift it to a CRRT. So first for a day or two you do IHD, then shift to CRRT if possible. Okay, so this is the first choice extracorporeal modality which can be available everywhere. Okay, and it has a rapidity of toxin removal, but the thing is it only removes the low molecular weight toxins. Okay, so that is about the intermittent hemodialysis. Now coming to your CRRT, CRRT can remove higher molecular weight substances. 20,000 to 40,000 Dalton substances can be removed through CRRT. And the important advantage is here, the rebound of toxins will be comparatively less as seen in intermittent hemodialysis. Okay, that is the advantage. But disadvantage is that its efficiency is very low compared to IHD. Okay, and here you will require an intensive anticoagulation. So there will be an increased bleeding risk and electrolyte disturbances, and it will not be available in all the hospitals, and training and cost is the other disadvantages of CRRT. Now coming to the hemoperfusion or hemadsorption. So here usually it consists of a passage of anticoagulated blood through a cartridge which contains an adsorbent material like your activated charcoal or a resin. Okay. So in order to be removed by hemoperfusion, the toxic substance must have binding affinity to the sorbent in the cartridge, and it should have a low volume of distribution. So as I told, for hemadsorption, it can remove both water and lipid soluble substances, and also those substances which are highly protein bound, they can also be removed by hemoperfusion. So these are the two advantages. Lipid soluble drugs and high protein bound drugs can be removed by hemoperfusion. Okay, and centrifugation technique, as we all know, basically centrifugation, it separates the whole blood into various components according to their specific gravity. So in the treatment of a poisoned patient, the guidelines recommend an exchange volume of 1 to 2 total plasma volumes per day until the clinical symptoms have decreased and the release of toxin from the tissue is no longer significant. So this also can remove highly protein bound poisons. And also, if you see, the molecular weights over 50,000 Daltons can be removed by your centrifugation techniques, especially your monoclonal antibodies. But if you ask me the efficiency, it is very, very poor. Okay, so the clearance capacity is very much low compared to your other forms of extracorporeal removal. Okay, so other than your monoclonal antibodies, some support for this centrifugation process is your mushroom toxicity, thyroxine toxicity, vincristine and cisplatin toxicity. These can be removed with the help of centrifugation because the molecular weight of these are more than 50,000. So this is how you approach. If you think of any patient to subject to extracorporeal removal of toxin, then you need to answer all these questions and then fix upon what type of uh, modality I should use. Okay. So first one is the exposure to poison likely to cause any serious morbidity or mortality? The indications which I told. If it is yes, okay. The second is there any antidote which is present for this toxicity? If there is no antidote, then comes, can the poison's toxicity be minimized by treatments that prevent absorption and or enhance elimination? If it is no, then comes your first. See whether the poison's endogenous clearance. So first comes your clearance. Second comes your volume of distribution. Okay. Third comes how much is it protein bound. Okay. If it is more than 95% protein down, less than 80, between 80 to 95. If it is more than 95% protein bound, then it is therapeutic plasma exchange that you need to do for that poison. If it is less 80 to 95%, then it is hemoperfusion. If it is less than 80, then you should check the molecular weight of the toxin. If the molecular weight toxin is much less than 500, intermittent hemodialysis, up to 15,000, high flux hemodialysis, 15 to 25 kilodalton, hemofiltration or your CRRT, 25 to 50, hemoperfusion, more than 50, therapeutic plasma exchange. So this is how you need to go about when you think of extracorporeal toxin removal. Okay. So now examples. A lot of drugs can be removed extracorporeally. So you have your aspirin, digoxin, lithium, paraquat, beta blockers, barbiturates, methanol, tricyclic antidepressant, sodium valproate, carbamazepine. So this is the table which gives you about the drugs that can be removed, what are the indications, what are the other forms of treatments that are, or the antidote which is present for this drug. So if you have time, you can go through it. Otherwise, I have given one last slide. If you remember that last slide for the exam, it's more than enough. And this is the one important thing that you should remember. The XTRIP group, which I mentioned before, has recommended, okay, against the use of extracorporeal therapies to tricyclic antidepressants and digoxin. It has a neutral opinion on phenytoin. It is can be used for acetaminophen and carbamazepine, but they have 100% recommended for your barbiturate toxicity, lithium, methanol, metformin, salicylates, thallium, theophylline, and valproate. So these are the only drugs which is been recommended by the XTRIC group to be removed by extracorporeal therapies. Okay. So this is the last slide which tells about the indications of extracorporeal therapies for some important drugs which I have discussed, the recommended drugs. Okay. For toxic alcohol, what are the concentrations? Okay. That is especially for your methanol. Second, for salicylate, what should be the concentration? And if the patient has underlying kidney disease, what should be the concentration of the salicylates? Okay. Acetaminophen poisoning, lithium, metformin, and your lithium and metformin. So if you write any one of these when they ask about extracorporeal removal, one drug and its indication, if they ask for 5 marks, so you're going to write the definition, you just mention about the XTRIP group, indications, and the properties of the drugs. Okay, the 5 properties, very, very important. Then comes your uh, different modalities by which you can remove, and you can write about indications of 1 or 2 drugs. Okay, so that will complete the 5 mark question. Okay, thank you.